My name is Leslie, and I work for the Federation for Children with Special Needs. And I'm so happy today to welcome Dr. Renée Marchant and Stephanie, I'm going to say it wrong, Monaghan-Blout.
That's right.
Yay. And both of them have a lot of expertise in this area. We're going to talk about trauma-focused evaluation and treatment. Dr. Marchant is a pediatric neurologist, neuropsychologist, and does evaluations and works in therapeutic interventions. And Dr. Monaghan-Blout is also specializing in neurophysiological and psychological assessment. So I'm just going to let these experts go, and we're going to save the questions, if you can put them into the chat box, and we'll reserve some time, 10 to 15 minutes at the end, to address your questions. Thank you so much for joining us. Take it away.
Thank you, Leslie. Right.
So thank you all for being here today. This has been something I've done a number of times, and Renee, I think you've done some of these as well. This is I always really enjoy coming to speak to this group and you guys, because it's a very savvy group. You guys know a lot, and I always learn a lot when I come to speak with you. So today what we're going to be talking about is really trauma-focused evaluations and treatment of family and systems lens. We're going to try to really sort of expand our thinking to be more of an inclusive idea of how to really get our heads around both how to identify trauma and how to help people deal with the consequences of that. So you want to do the...
Yeah, so I also want to say too, I think that both Steph and I, one of our kind of passions, I think, is bringing family and systems work and that lens into neuropsych assessment, which is definitely a critical need in our field and very important in how we treat kids and families.
I have to say, when I told my family therapy colleagues that I was going into neuropsychology, they thought that I was just going to the dark side, basically, because of the lack of a systemic viewpoint. But I think both Renee and I really feel that that's not necessary. That doesn't have to be true for neuropsychological evaluations. And in fact, we should, that especially for children, we have to be looking at these things from a systems lens.
Exactly. So our objectives for today, Steph is going to start us and have a thorough discussion about the stress response and trauma and what that looks like, as well as discussing from there how we evaluate trauma and stress and understand trauma and stress in evaluations. And then lastly, I will speak to and have a discussion about treatment interventions for trauma across this systemic lens, which is including home, school, and community, and what that looks like for recommendations in neuropsych evals.
So I want to spend a little time on the history here, because I always think, and we'll be talking throughout the rest of this, the context is really a critical component to understanding and the meaning of what we see in front of us. And so PTSD is a diagnosis that's fairly new. It was developed during the Vietnam War, and it was based on the experience of veterans and the experiences that they came back from after having experienced some pretty awful things. Again, it's been around for a really long time. I think there are some talk about, even some of the ancient Greeks have talked a little bit about it, but we mostly talked about the shell shock of World War I, of the soldiers who were stuck in those horrible trenches and the ways that they came back and were really traumatized and marked for life. And at that point, it was considered to be sort of like many things at that time, sort of a mark of lack of character in some ways. In World War II, I think it was called combat fatigue. And by the Vietnamese War, we really found that this was really something that had, the capacity that it involved that idea of sort of going beyond, being in experiences that go beyond and completely shatter all of our customary ways of sort of coping with what's put in front of us. The problem with PTSD, and people love the idea of PTSD because it finally captured and named something that was really important, that people knew about it. But it was based on soldiers. It wasn't based on, a large majority of people who also are experiencing some pretty awful things that really marked them for life in some ways. And although it was sort of, we tried to sort of fit people in the, like the square peg in a round hole, it became very clear that this didn't work very well. Some of the earliest people who really talked about this were Judy Herman and Mary Harvey, who were in this area, and they talked about women who were victims of domestic violence, and also women and children who have been caught in war-torn environments. I was actually thinking that Lenore Terr was also an early a person who did a lot of research on and talked about this, and she wrote a very famous book called Too Scared to Cry, and it was really about the psychic trauma in children, and that was published in 1990, I think. And that was really an important aspect of it, because even when they talked about domestic violence, even when they talked about women's experience, it really, again, didn't really fit. And then there was a very famous study actually done through the Boston court clinic that looked at kids who had been adjudicated maltreated, who didn't the majority of those kids didn't qualify for a PTSD diagnosis, because that's not how they exhibited the things that had happened to them in their life and how they were trying to handle it. At the end here, I talk about it. It didn't capture the description, the presentation of children who had grown up in environments lacking the basic physical and emotional necessities, and where violence was a part of the fabric of their lives. So what has happened in more recent years, in the last 20 years, is we've really tried to capture that diagnosis in a little bit of a better way. And there are a number of different ways of doing this. The one that I tend to like a lot is by Bessel van der Kolk. It's called developmental trauma. But there's also complex trauma is another variety, and that's actually used by the National Child Traumatic Stress Network. But the developmental trauma disorder really tries to capture all the aspects of those salient aspects of what trauma does to developing children, to children and people who are developing. Okay, go to the next one, I think. So the DTD symptoms, they include the basic one is an exposure to multiple or prolonged adverse effects over periods of at least 1 year, beginning in childhood or early adolescence. It causes affective and physiological dysregulation. It causes attentional and behavioral dysregulation. That's the impaired development of sustained attention, learning, or coping skills to manage stress. And it causes self and relational dysregulation, or the impaired ability to get a sense of personal identity and involvement in relationships. And those include three of the following. Okay. So the functional impairment really causes a clinically significant distress or impairment in at least two of the following areas of functioning: scholastic, familial, and peer group. And this is all going to make a lot of sense to you for those of you who are working with children who are really struggling with the impact of trauma, because these are areas that are typically pretty impaired. So just before I just go on with it, I just want to make sure that people understand a developmental trauma disorder and complex trauma are not, these are at best can be called provisional diagnoses. That means that they're actually not in the DSM-5. There are sometimes they're at the back of the book, sometimes they're kind of mentioned in passing, but they have not been accepted as a standard way of describing the impact of children. They're still trying to sort of stuff children in some ways into the PTSD diagnosis, or actually the diagnosis that's used now sometimes for these kids is other trauma and stressor related disorders. But there's not, but again, these are square pegs for round holes, or round holes for square pegs, and they don't really express that. And it's important for diagnoses are there to help us. They're helping us to tell us what the picture is and where we need to go with there. And if our diagnoses don't support what we're seeing, they don't really make a lot of sense, and they aren't very helpful. What constitutes trauma? We learned that it isn't just being in life-threatening situations, or rather, it doesn't have to be a war that you have to be in. So trauma, it involves witnessing domestic violence or community violence. It involves abuse, physical, sexual, or psychological, especially that which occurs within the context of relationships. So it's one thing if some guy off the street comes up and hits you really hard, but it's another thing if it's your parent, your mom and your dad that you love very much, and they hit you very hard. And then the third piece of this is the neglect. It involves the neglect of physical, social, or emotional needs. So, but the issue with trauma and with kids, it's not that simple. It's not like, did something bad happen to you? Okay. Neglect, abuse, and witnessing violence often occur together. Some children are more vulnerable to these adverse experiences than others due to pre-existing factors. For instance, prenatal exposure to drugs during pregnancy can really impede the development of other kind of cognitive resources that could help you deal with bad things happening to you. Malnutrition does the same thing. Malnutrition in small children, in infants, really impedes the development of whole cortical systems that are important for later regulation. And then again, maternal stress. So if your parents are incredibly stressed out, if your mother or parent is being physically abused, if you're homeless, if there isn't enough food, if mom's going back and forth trying to figure out how to feed you, but there's no one to take care of the little kids, and it's you're a 4-year-old, and now it's your responsibility to take care of a 2-year-old. Those are all incredibly factors that sort of feed in. And then again, children are also exposed to secondary impacts. And again, this is the maternal depression is actually something that's really, we're finding out more and more how really significant this is, not only just on the mother, but on the children as well. And so for many reasons, a mom who's struggling with postpartum depression can't be the mom she wants to be, but that lack of her presence really has a tremendous effect on kids as well. Okay. So why are children so vulnerable? The threshold of trauma is lower. And you have to think about helplessness of young children. What's life-threatening for young children, it's not the same as what's life-threatening for an adult. So for an adult, what's life-threatening is your car is going off the cliff. For a toddler, it's the fact that you're wet and cold and hungry and nobody's coming to help you and make you feel better. All right. That's for a helpless child, that's life-threatening, really. The other thing is that when children their brains are growing, in the last trimester of pregnancy and the first 2 years of life, the brain increases in size by four times. Anything that, things that happen during that period of tremendous growth really have a tremendous effect on the trajectory of development. When kids' brains get distorted to actually focusing on detecting threat, they become incredibly good at detecting things that could be threat. Not so good at paying attention to what their mom is saying and making connections between how things happen when you drop the spoon and it falls to the ground, kind of things. Again, the cost of this being stuck in red alert, while it may be in the moment an adaptive response, and we'll talk more about that in a minute, it has a lot of other effects that are really much more problematic. And these include physical illness, learning problems, social difficulties, inappropriate medications and interventions, and eventually substance abuse. I just want to point out here too, this, you all are familiar, I'm sure, with the ACE study, and that really looked at members of the Kaiser Permanente health insurance plan and found that there is a direct relationship between higher levels of bad things happening to you when you're a kid and higher levels of all kinds of physical illnesses. And this includes not only things like heart disease and diabetes, but it also includes reproductive problems, menstrual problems, and difficulties with fertility as well. So there's the ripple effect of all of these bad experiences at an early age really move out and out and out. Okay. All right. So one of the questions is, and this is something that comes up actually quite a lot, which is, do traumatic events always result in trauma? And the simple answer is no. There are a lot of kids who've gone through some pretty horrendous experience and do not become permanently traumatized by it. The response to children who've experienced really bad things happening to them is really mediated by the genetic profile. That means, do they have a family history that's largely absent of things like depression, anxiety, and other mental health issues? How old the kid is and in what stage of development were they at? A 6-year-old has a lot more resources than a 2-year-old, who has a lot more resources than a 6-month-old. and cognitive and pre-existing conditions. So again, being smart won't help everything, but it helps a little. And also pre-existing conditions, for instance, kids who have autism spectrum disorder are incredibly vulnerable to trauma in a way that a more typically developing child wouldn't, because they don't have the same kind of sort of social resources and even cognitive flexibility that older children might have. Another important thing is the duration and severity of the trauma. So a one-time hit is one thing. A kid who's been living out of the back of the car and food isn't always around, their parents have to leave them for long periods of time, that's a whole different ballgame. And then the other important issue is protective factors. And I'm going to just mention these quickly, but this is something that Renee is going to talk more about. A psychosocial support, including and especially a caregiver's response to the child. A caregiver who can either protect or mediate a little bit of the trauma, but it can also be there in a consistent way so the child doesn't feel alone in the world. And also a child's feeling of mastery, which includes both a sense of agency, can I have an effect on the world, and also recovery of meaning, can I make sense of what has happened to me? Okay. So the anxiety experience, anxiety is when we feel helpless and out of control. Cognitively, if we're a thinker, we may be a lot of worrying, catastrophizing, rumination. Some of us are more people who experience anxiety in our bodies. There's muscle tension, restlessness, heart palpitations, sometimes panic attacks. And then there's the manifestation of the stress response, which is what I'm going to talk about now. The stress response is actually looks at this from a more physiological capacity rather than the subjective experience of anxiety. So, and in fact, and this is what I really want to emphasize, stress is an adaptive response. Stress gets you up and out and moving and doing something about a situation that's feeling really scary and overwhelming and threatening to you. And it's really the physiological process by which our body prepares to deal with anger. All living things have some form of a stress response, and if they didn't, they wouldn't be around. It's really critical for survival. And it's a way of protecting us from my favorite guy, my tiger, okay? My scary tiger. And it's the way that your body gets ready to deal with this kind of danger. So briefly, the stress response is a cascading and complex sort of symphony of hormones, actually, that make things happen. It's what they, signals to your brain that something really, that your brain picks up and things look like a threat. Switches on systems that are need to respond to that threat. That's your sympathetic nervous system. That's your fight or flight system. It switches off systems that are not essential to the crisis response. That's the parasympathetic nervous system that's expressed in digest. That energy that used to go to them is now available and ready to be there for the sympathetic nervous system to get ready to go. Your heart rate hasn't increased. You're breathing faster and you're getting more oxygen in your air, and there's glucose that's being released to your body in the form of cortisol, so you can have the energy that you need to respond quickly and get out of the way of the tiger. Okay. Now, once the danger is past, the parasympathetic system takes over, comes back up and takes over, calms things down, smooths it out, brings you back down to baseline. All right. Okay. Your heart slows down, your respirations become deeper, and most importantly, you start thinking again. Because one of the things that the sympathetic system cuts off is this cuts off all access to your higher level thinking system. Because you know what, you don't need to be thinking about the complexities of, is it what kind of a tiger it is, and our tiger is really upset. You need to just run. You don't need to worry about what the tiger is about. You need to just run. And that's the thinking process. Okay. So the fight, flight, and freeze are our stress responses. Flight responses tend to be more active. They're impulsive, hyperactive, defiant, aggressive. It's in the classroom, this is the kid who goes, "You can't make me, and I don't want to, and I'm not going to do it." And the pencils may start to fly, books drop on the floor, and it's chaos. These kids often get labeled as bad kids or behavioral kids. And what people are missing oftentimes is they're actually scared kids, right? Flight is the avoidant, distractible, spacey kid. The kid who just can't say focused on what the directions are, keep saying, going, what, I don't understand. The kid who just really has to go out to their locker to check to make sure that they actually did bring their spatial mittens, or the kid who's just, again, very spacey. This is also a kid who ends up, wanting to go to the nurse's office very often. And again, these are kids who are often considered to have sort of quote unquote behavioral issues as well, when again, these are scared kids. And the freest kids, these are the kids who shut down. These are the kids who can't make a decision. They can't get started, they can't stop. They have a lot of difficulty shifting gears. These kids are also, again, I hate to tell you how many times I've seen in, sort of behavioral plans and IEPs, that the kids should need to be rewarded or they need to be discouraged from shutting down. That's considered to be in some ways a non-compliance in that regard. It's considered to be a behavioral issue. When again, these kids, a lot of these kids can't even talk at that point. They're just so flooded with fear. Okay. So we have this whole wonderful hormonal system that goes around and around, gets us all hyped up when we need to be hyped up, calms us down when we need to be calmed down. But the question happens, what happens if this loop doesn't shut down? What happens if, it just sort of keeps on sort of repeating itself? If the danger is more immediate, if their danger sensor is too sensitive, like we're too good at detecting threat, or if the body never gets a chance to calm down. In that situation, the person remains activated, looking for danger, ready to respond, even when it's not appropriate, even when it's against their best interests. I want to just remind people that anything that we practice, we get better at. We practice at good stuff, we get better at good stuff. We practice at things that get in our own way, we get really good at that. Kids who live in situations that are dangerous and scary all the time get to be really, really, really good at detecting anything that's different, a little bit of different stuff. And that gets, that skill that they have really gets in their way in most situations. Again, if you think back to the response to the fight, flight, and freeze responses, in the classroom, those are not particularly adaptive responses, but that's what the kid has and that's what they're good at. So impact of trauma, chronic fight, flight, and freeze. Your attentional system is geared to be on the lookout for danger or triggers. Your arousal set points are too fixed. Either you're too revved up or you're too spaced out. But you're not in a situation of a calm alertness that allows you to take information in, learn, and respond to the environment around you in an adaptive way. It distorts perceptions of people and event. If you're always looking for danger, if something unusual or unexpected happens, the bias is going to be, that's a bad thing. Okay, kid bumps into you in line, they did it on purpose, they hate me. All right. It drastically limits the capacity for flexible thinking and creative problem solving. Again, those higher level brain functions are cut off. You don't have access to all that good stuff, the good critical thinking skills. You're just sort of, it's very, very black and white. Okay. And then also, and I think this is really important too, and I think this is something that often is missed, is that it creates conditions of physical comfort. It's really uncomfortable to be tense. Tension leads to tension headaches, it leads to stomach upset, it leads to a lot of things that are a lot of physical illnesses and physical discomfort. It's important to recognize. All right. So in short, stressed, anxious, and traumatized children who are constantly on the outlook for danger are not available for learning. All right. Just trying to see how much more time I have for you. Okay. So this impact of trauma, behavioral presentation, we've talked a lot about this, but it can look like attentional and executive function problems, like ADHD. Kids who are traumatized and are in a stress reaction don't have really good language. Again, that's a higher level function. They have a lot of behavioral dysregulation. They may be under the table. They may be running through the door. They may be refusing. They may have their head on their desk and they won't pick it up again. These kids are depressed, anxious, and they often engage in self-harming behaviors. They may have a lot of problems with learning, and they may have, and typically their social skills are really problematic. These are also kids who are really at high risk for, as they reach adolescence, to get involved in substance use and abuse as a way of self-medicating. All right. So just because this is something you advocates out there always ask, is there a test for trauma? No, there's no test. There's no neuropsychological test. okay? But can we determine the impact of trauma on children through neuropsychological testing? Yes, we can, okay? And we're really sort of looking for we can't, it's like anything else. Our competency is not, telling you what happened and where you got traumatized. It's looking for the impact of the trauma on the systems that affect, again, remember, academic, social, and community functioning. All right. So neuropsychological testing attempts to connect brain function with behavior, and it relies on quantifiable activities that can be transformed into these statistical procedures that give you scores. That allows us to compare kids across age, with other kids their age, but also as they grow up. We use things like Z-scores, T-scores, standard scores, and scaled scores. These are the scores that are transformed by these statistical procedures. Right. You guys probably are familiar with this, with our normal distribution or our bell curve. And what we a lot of times are looking for is that thing, that same as others, one in the middle. That's the 25th percentile, the 75th percentile. And when kids fall in that range, we pretty much don't worry about them. When they get into the tails, which happen less frequently, then that's something that we really comment on. Okay. But we have to be really important. Remember that numbers are just numbers. And without the context, without understanding who this child is, what is their history? How do they function in schools? How do they function at home? How do they function with us in the testing room? That's what I'm talking about, context. And how is it that they do things? Yes, the kid might be underneath my desk, and that happens fairly frequently. Renée can tell you as well. But why and how and when do they end up under the desk? That's really important information. Do they do it at the beginning of the session? Do they do it at the end of the session? Or do they only do it when I bring up math? I mean, that's important, all right? These findings need to be clearly associated with function. What's the referral question? And they need to address the demands of each child's environment, which is, again, 100 years ago, what a learning disability would have been, which were the kids who had fine motor problems and they couldn't do a lot of or gross motor problems, and they couldn't do a lot of the demands of their environment was such that they could not meet those demands. It's really different now because of our, now it's, can you read and write? That wasn't so important 150 years ago. But in our environment, that's what a learning disability is. I'm going to go over this fairly quickly because I want Renée to get a good chance to talk about this, the treatment stuff. But something, again, when we talk about context, who this child is, and what they bring to the table, here are some things that we really need to know about and consider before we talk about the impact of trauma, which is, is this a kid who has significant visual perceptual problems who may have difficulty processing a lot of the test material? If you have a kid who's got low vision, for instance, is there enough contrast in the materials so they can actually, if you look at, a contrast, when I'm talking about contrast, is like the dark background of this slide with the white print is one thing, but we actually had some of our slides had some navy blue print in them, and you couldn't see it all. If there's no and that kind of high contrast is really important. For instance, if you have low vision, kids with significant language issues who may have difficulties expressing or organizing their ideas. We see a lot of kids who the information gets in, but they don't have the language capacity to organize and get it back out again. So if I don't know that, I might think things really, really see this kid in a very different way. Kids with significant cognitive limitations who don't have the capacity to have more abstract thinking. These are kids with intellectual disability. And kids with significant deficits of social cognition like autism spectrum disorders. This is particularly tricky because again, going back, kids with on the spectrum are incredibly vulnerable to trauma. To figure out what's trauma and what's their autism, it can be often quite difficult. And then again, people whose emotional issues can interfere with processing information. And this is something that comes up a lot, really, with when kids really bomb on our tests. We have to think, well, why? Why do they bomb on our tests? Did they bomb on our tests because it reminded them of a teacher in first grade who made them sit in the back of the class because they were too stupid, or is it because they couldn't do math? So, all right. The structure of a neuropsych evaluations, we want to include all this information. We want a good referral question. So that times we're going to spend a lot of time with people saying, what really do you want to know? Okay. We want to make sure people know what information we use. We didn't just come up with this out of our own. We use, and these are the kind of tests that we use. These are the people that we talk to. We want to know relevant history. It's very relevant history to know that this child had 5 different caretakers before the age of 2. That's really, really important information, okay? Previous evaluations to see how kids are doing. You know, are they making the kind of progress we think they're going to make? And if they aren't, we need to find out why, okay? Description of their test results. What did we actually find, okay? And can we translate that into like words that people know and understand rather than our jargon? Impressions, how are we putting this all together, and what our recommendations are. This slide, I'm going to go through fairly quickly. Again, the question is, who is this child and how did he get to be where he is today? And these are some of the factors that need to really be included. Again, that family history and psychosocial stressors, birth history, medical history, how they got to develop, you know, walking, talking, learning to eat, feed themselves, picking up, you know, getting along with other children, and picking up, you know, early school skills like numbers, letters, and colors. Right? Educational history. Is this a kid who actually stayed back, you know, was kept back in first grade because they were having such a problem socially getting along with the other kids and sort of going along with the whole expectations of the classroom? Is this a kid who's on an IEP? You know, does this kid have friends, or is this kid completely friendless? And has this kid, you know, emotional history? Has this kid had diagnoses before? Have they been hospitalized? Okay. And again, family and systems matter. So it isn't just, we really want to know from as many different data points as we can how this kid functions. Okay. I think this is something that I don't know if all people really understand about how important our behavioral observations are, and how every aspect of the testing situation gives us really important information. You know, how does the child manage in the waiting room? You know, is this the kid completely ignores when I try to talk to them and they ignore me completely? How do they make the transition to the Western room? Do they bury their head in their mom's lap and won't leave? Do they need to have mom sit in the waiting room, sit in the testing room for the first session, and then maybe they'll let her leave, okay? This is the change over time, you know? Do they get more comfortable or less comfortable over time? How do they respond to my accommodations? Do they ask for it? Do they say, can I take a break? I don't like this pen, can I try a bigger one? Do they accept my offers? What if anything changes? Are there specific triggers that change the way a child's response is? So that, for instance, that can be, like for a lot of kids, it's really pretty intimidating for them to be in a testing room. And if I make a list for them, a checklist that they can handle, that they can have right next to them, and they can see exactly how many things they have to do till they get to the break, that can really make a big difference. These are the areas that we generally cover in neuropsych evaluation. We look at cognitive, academic, language, visual perceptual, visual spatial, visual motor, memory, attention, and social emotional functioning. Okay. I'm going to go on. Yeah, I'm not going to. And then this is the important stuff, which is the integration of findings from the impression section. Let's be clear. This is the meat and the really important part of the evaluation. So we try to start out by restating, okay, what are we looking for? What do we start this with? What do we want to know about this kid? And how do they handle the whole situation? What are the relevant findings? It doesn't have to be everything. And in NESCA, we don't talk about everything that we did very specifically. We include that information in our table, but we only talk about the stuff that's really important. And then a formulation of what this all means. What is going on with this kid and how is it best described? And then we move on from that to talk about really how do these issues play out in a child's functioning at home, in school, and in the community, and how do they fit with a referral question? If this is a kid who's really stuck in threat alert, what does that look like at home? What does it look like at school? What does it look like in the community? At home, this kid may be a kid who does a lot of tantruming. In school, the kid may be actually quite withdrawn, and it's very difficult to get them to talk. And in the community, they have a really hard time engaging. They're the kid on the soccer field who's always off in the corner and won't really engage with the other kids. The recommendations really need to address the referral questions and the main findings. They need to be explicit, and they need to connect the dots. You need to know why and making a referral. So for instance, it might be that this kid needs to be in a very small classroom. Why? Because they need a lot of individualized attention. They need a lot of reassurance. They need someone who knows they need to know they're being seen. That can make a huge difference for a lot of kids who are traumatized, to know that someone cares about them and is looking out after them, and is looking, making sure they're doing the right thing, can be such a relief for them to know that. And that's really impossible to do when there are 20 other kids in the classroom. And it's important that this is sort of reader friendly and accessible. And it needs to be directed, like, I'll write different kind of recommendations for a kid who's on an IEP than I will for a kid who's in a private school. And then the trauma-focused recommendations, it really needs to be addressed specifically to that child, okay? So for instance, if a kid's a fight kid, let's put it this way, everybody has some form of fight, flight, and freeze. We tend to sort of have preferences. Some of us are more fight people, some of us are more freeze people. Our recommendations need to be addressed to specific, what is our particular style? And I talk a lot about what the tells are about trauma. When a kid starts putting their head down on their desk, that's a pretty obvious tell that something's going on with the kid. Don't ignore that and don't just call that behavior. What's going on with that kid? And what can I do for that in that moment? Is there a step that's before on the head on the desk? Maybe it's the stretching out, like sort of sinking underneath the desk kind of thing. Maybe that's the step before the head goes down on the desk. That's the time that teachers can intervene and come over and say, hey, how things going? You look like you're having a little bit of a hard time with that over there. Because once the kid's head on the desk, it's really it's going to be harder to engage them and to get them out of that. And then again, what are the resources the child has in the larger community and school system, and how can we utilize those things? That's a lot of what Renee is going to talk about as well. So.
All right, thanks, Steph. So what I'm going to focus on, I actually have a diagram to start us off with, piggybacking off of what Steph is describing. We've talked about what the trauma response can look like in kids, how we might evaluate the trauma response and stress for kids who come into our office for neuropsych testing. Now we want to talk about how we craft our recommendations for kids who have experienced trauma. Importantly, as Steph said, there's no template recommendation. We have to be very individualized and specific to what this child looks like and what their functioning looks like, and therefore what their needs are. I think to start off in thinking about how we recommend taking care of kids and supporting kids who've experienced trauma, I put this diagram, which is Bronfenbrenner's ecological systems theory. So if you look at, this is kind of a target to show you some of the different systems that are impacting kids. If we can imagine, a child or an adolescent is in that kind of green circle in the middle, right? And then we have all these different systems that are interacting with that child: family, school, community, right? So neighborhood, parent work environment, extended family. Then of course we have broader systems like the mass media, the conditions, right? The neighborhood conditions, the social conditions, how broader laws affect service delivery for kids, how broader laws affect their experience. And so I think Steph and I both feel very strongly that, when we're looking at even what the research says about how we treat trauma, it is all very much based in relationship. And so in order to impact kids in a positive way for treating trauma, we really have to consider these macro level systems and how we address these systems in order to treat the green dot or to treat the child that has been traumatized. So I put this here to think about, if we think about this, obviously you've heard that phrase, it takes a village, right? And if we look at this, there is a large village network that is needed to support a child. And one of the things that we talk about in, for example, coping skills and coping strategies that we want kids to learn is that it's really important that kids learn how to generalize those skills across different contexts, across different settings, right? So in order to do that, we really have to have all hands on deck. We have to have school on board, we have to have parents on board, we have to have the community on board to really help generalize skills that we're talking about. So, as we know, and as we talked about, there's no cookie cutter recommendation plan for kids who've experienced trauma. However, I think when we look at the research and we look at I mean, even in practice, Steph and I in practice, what are the goals that we're thinking about when we're creating recommendations in an evaluation for a child who's experienced trauma? What's the goal for this village, right? This family and systems lens that's really important. We think about two important things: developing connection to others, which helps kids feel safe and competent, and developing self-expression and mastery, which Steph talked about at the beginning of this presentation. These are really two important goals and two domains that we see, and if we look at the research, is very important for how we treat trauma for kids, for teens, and for the systems that care for them. So how do we do that? I'm going to dive into some of the potential treatment options and what that might look like for how we develop these important goals for kids who've been traumatized. Broadly speaking, we want to find effective psychotherapy treatments and determine what that looks like for a kid based on their learning profile, based on their family, based on their needs, right? And we also want to not just think about a child in a room, having wonderful trauma-focused therapy, which is very important, but also how does the system support them outside of that office, at school, in the community, out in the grocery store, all the things that are important for our kids to function. So I'm going to speak first about some of the information and research that we know about treating trauma in therapy. Again, there's no one size fits all, and that's really critical, I think, for us to remember and think about when we're determining recommendations for kids for treatment. However, we do know that trauma-focused treatment impacts positive coping for kids and recovery from trauma far better than just treatment as usual. So not having kind of a formulation or a guidebook or specific expertise and training in trauma, we see that kids who are in trauma-focused treatment do fare better. Some of the particular models or methods that many of you may be very familiar with or have been involved with in caring for kids is trauma-focused CBT, ARC, attachment, self-regulation, and competency, parent-child interaction therapy. There's also research to speak to more family systems interventions like attachment-based family therapy, particularly for kids who have experienced significant attachment disruptions or might present with a more developmental trauma-related profile, as well as structural family therapy and some of our family therapy models that involve the whole system. I also include, Steph, I think you mentioned this too, so UMass Medical Center, the National Child Traumatic Stress Network, they have a centralized referral line, which I included here, that many of you are probably familiar with as well, but I really love this resource. It's free, it's available for the community, and you call them and you explain what's going on either with your child or someone in the community that you're worried about, and they talk through kind of what are some potential options for a referral for an appropriate, finding an appropriate provider who can provide the right trauma-informed treatment like TFCBT, PCIT, or ARC as listed here. So it's definitely an important resource to keep in mind.
Just for people to know, the Central Mass seems to have a really good focus on this whole issue of child trauma. There's also a new, I think it's the National Child Traumatic Stress Network is funding some more programs to actually do training for teachers and service providers in the Central Mass area. And they're working closely, I think, with this, with the UMass Medical Center in any case. So
yeah, and it's definitely great in terms of even just figuring out like the insurance piece and having like a big database of who's out there to support a child who really needs this treatment. They're definitely a good first step. Okay, so I want to take kind of a step back. I've talked about really specific trauma-focused treatment in therapy, right? TFCBT, attachment, regulation, ARC, PCIT, and we started thinking about all the systems and all the context and the story that children come to the table with when we see them in evaluation. And importantly, I think we also have to think about this very important narrative or story that all of us carry with us, which is social and cultural trauma, right? And there are important treatment considerations for how we understand and acknowledge and appreciate some of the social and cultural significant traumas that many kids and teens and families experience. What I'm specifically talking about is intergenerational trauma, racial trauma, right? and thinking about how, Steph had mentioned, it's not just about the numbers, right, that we might get in a neuropsych evaluation. It's not just about the green circle or that kid in the middle of the circle. It's also about the broader systemic environment and the culture that is surrounding our kids and what it means to be that kid in our world. So we know in the research that a lot of isms, so racism, sexism, heterosexism, cause stress and create a lot of stress and trauma in populations across the world, right? There's also some research around increasing cortisol levels in parents, right, who experience racial trauma or segregation in earlier years. And as Steph had mentioned, we can imagine there being a lot fight, flight, and freeze responses that we see in kids who experience racial trauma, who experience intergenerational trauma. And so in many ways, we see these fight, flight, freeze responses that are the tip of the iceberg. And underneath, we have families and kids who carry a story of significant oppression, trauma, and significant anxiety and difficulties that stem from this challenge. So for example, there's studies on Holocaust survivors, and later, if we think about the Holocaust, what had happened to now, there's a number of years that we can trace that there are increased cortisol levels, that there's higher levels of anxiety, higher levels of stress, some physical diseases like heart disease and whatnot that are more prevalent in families who may have that intergenerational story or narrative, even if they haven't experienced that trauma firsthand. We know that people of color experiencing institutionalized racism, oppression, microaggressions, racial profiling, right? These are all really important aspects of their life that are so critical and have a traumatic impact on their function. And so it's really important, both Steph and I feel this very strongly, and in our psychological community, for there to be an acknowledgement and a cultural humility around this impact on functioning and what that looks like for a child in everyday life, at school, in their community, and whatnot. Steph, were you going to say something?
Yeah, I was just saying that I think one of the things that comes up a lot, and it's a really difficult situation, I think, is we have a lot of our kids come from international adoptions or transracial adoptions, and those kids, a lot of parents make a real effort to connect these kids with their own, so they don't lose everything. They don't lose their cultural identity as well. And there's some really wonderful groups that are doing really neat stuff around that. The oldest one of them is the Open Door Society. But many of our kids go to school where there's no one else who looks like them. Teachers don't look like them, kids don't look like them. And then it just sort of intensifies that sense of being alone and different. And if it's the one thing that we white ladies can do is maybe sometimes say, let's look around and see if there's anybody, who has the same kind of, who these kids can identify with in these environments. That's the ultimate of the macro system kind of thing.
Yeah. Yeah, and I think what, as we were talking about, this kind of importance of cultural humility and being really, acknowledging and open to having the right skills and training to explore this with kids and with families. Yeah. Because one of the worst things that can happen in an evaluation or in a treatment is if we silence this and we don't, recognize and appreciate it. And so, we see in some of the family therapy literature and some of the literature on working with families and systems is that giving social, cultural, intergenerational, racial trauma a voice and acknowledging that is really critical in healing and making gains, as well as I indicate here, engaging with the community in an appropriate manner and how it works for the family. So my example for this is when I was training, I was in Utah for a year working with a number of LDS and Mormon populations. I saw a number of LGBTQ youth who were really isolated and lost in their faith because they were not understood and heard by members of their congregation. And so a lot of my treatment for a child who had been traumatized and bullied amidst their social cultural context was actually connecting with an LDS bishop who was accepting and acknowledging of differences in the faith, right? And that was actually a critical movement and growth for that child in treatment. In addition to the coping skills and all the strategies that are critical, right, in order to have that systemic understanding and acknowledgement was key for that child. And so I think that speaks to the importance of, we think about treatment recommendations, even in evaluation, how do we think about the broader community and what that means for treating this child and for growing their skills? So we also, Steph and I feel very strongly about this. There's also a lot of research in terms of trauma-focused work of how we work with the body, how we manage that stress response that Steph artfully described for us. If we think about it just very globally, how do we help kids and teens discharge failings rather than bottle them up and keep them all inside, right? Which is a natural reaction when we've been traumatized. And what we know is that rhythmic activities really help with self-regulation. So emotion regulation, managing your attention span, managing, your tasks and executive function skills. So we recommend very frequently, kind of the non-talk therapy interventions that are body-based, right? Like yoga, play for little kids, mindfulness, the extracurriculars that are really critical, like sports and dance and volunteering. Steph, I think you were the person who taught me this, even Fitbits are ways to, kind of monitor and track all the bodily functions. So kids are paying attention to their bodily needs, right? That's also a critical step and critical aspect of how we treat trauma and help them feel more mastery, more connected to their surroundings. Steph and I have also shared cases and have seen kids who've done equine assisted psychotherapy, right? So working with horses, and kids don't want to talk, they want to work with horses potentially, right? And there's a lot of work and some research that indicates that's very impactful for kids who have various disabilities. And when we think about recommendations, of course, we're thinking about those two goals. How do we help kids connect to other people, and how do we build mastery and self-expression? Supporting caregivers and the people taking care of them in this process is absolutely critical. So, we have, of course, many options that can exist depending on the circumstances. These might be, having families have supportive community involvement members that they're involved with, like their church, or, a parent group that they're a part of. In-home therapy, of course, as we know, a lot of kids and families benefit from having people come into the home and have that shared experience of what it's like to work together as a family with a child who's been traumatized. And as neuropsychologists, we also think about the importance as kids grow and develop of important agencies that they should be connected with. So these are things like Department of Mental Health, Department of Developmental Services, and other community partners that are going to be critical to think about the different access points that kids can create, new interventions and whatnot. This is definitely critical for us as well in how we support caregivers. So to speak a little bit about school, okay, how do we build mastery and build connection to others, right? Those are our two goals for kids who've been traumatized, or kind of our global understanding of what's helpful for treating kids with trauma. We want to build an IEP and a plan at school that's appropriate, and that's definitely critical, a critical piece for how we offer recommendations in our reports and in a neuropsych. These are some examples, again, not one size fits all of what one child might need or another. So those can be things like having a home-based person that they go to, that they're connected with. It can be a counselor, it can also be a teacher or the gym teacher, right? To really build that connection and trust. Also, making sure there's really good communication, that being an important goal between what's happening for this child in the classroom and what's happening when they come home from school. Is this child, working really hard to kind of manage their feelings all day, and then they come home and they're exploding, right? They're out of control and really struggling. That's really important communication for the school team to be aware of. Self-regulation teaching, right? And teaching emotion management skills and regulation skills is critical. Making sure kids have access to coping strategies within the school building, motor breaks, quiet space, having access to sensory play, and all the other important aspects of school, like having the right academic instruction to build skill deficits that allow kids to feel more confident in school and outside of school, like having the right reading instruction and writing instruction and math instruction, depending on the child's needs and what would best support them academically. Similarly, the executive function and daily real life skill building is also an important aspect of an IEP. Thinking about, self-care and getting up in the morning and organizing your homework assignments. A lot of kids we see with trauma need a lot of support in executive functioning in that domain. Similarly, social skills, making sure kids, for some kids, who have been traumatized, there's many circumstances where they're really shut off from their peers, or they're really guarded and they're on constant threat alert, right? And so we want to kind of help them mitigate that threat alert by having access to appropriate peers in a smaller setting, grow connected.
And these are also kids that I think with the social skills, they may be okay if things are all going well, but if things are not going well, these kids can really make some big social errors that they need to figure out how to fix them. And that's another thing. I think teaching kids who are traumatized how to fix stuff is really, really important, because we all make mistakes and they make mistakes too, but for them it feels so monumental to, if I make a mistake, people won't love me. Look what happened to me when I was little, so.
Exactly. And, I think also thinking about, I think even the connectivity in schools, there's some kids with trauma that really benefit from having like the right cohort of kids, right? And sometimes there's the counselor or the teacher who really knows the class and really knows who this kid's peer group is. And sometimes making that one connection with the right friend is so critical for our kids.
Yeah.
So, we've talked about, and, the goal for this aspect of the presentation was to talk about what are kind of our overarching goals for treating trauma that we would want to include in a neuropsych and want to include in evaluating the impact of trauma on kids functioning across home, school, and community. And we wanted to end with just a reminder, we look at the research and we look at the data, the number one resiliency factor for kids is the reliable presence of at least one supportive relationship, right? That connection is so critical for how kids problem solve, how they develop self-regulation skills to manage their life and feel confident. And so really having that supportive presence and consistent support is so critical for how we kind of mitigate that fight, flight, freeze mode that kids get so stuck in. And so with that, we will end, and we thank you so much for your time, and look forward to questions or comments.
Okay, so we have a couple of questions that were posted to the Q&A box, and I suggest people do that. Someone is asking, when they don't have early family or other history, oh, it just switched. What should they assume? What questions should they ask? And what records or source can they look for? This might be for people who are working as a surrogate parent, may not have the whole historical background or medical file. How would you suggest?
That's a really tough situation. I have found that actually DCF, they're pretty good about getting a lot of records whenever they can. But the problem about sort of reconnecting kids with biological family, that's always a little tricky as well. I think it's probably better to start with, for a surrogate parent who has had their child sort of jumps into your lap and don't really know much about him. It's just to really start watching this kid and what makes this kid feel good, what makes this kid come alive and feel more responsive, and to sort of start to tune in there. Some kids I've had kids who church has been wonderful for some kids. Camp has been wonderful for some kids. Mm-hmm. Music, something that they love and is interested in, even if you can't sort of develop a relational or track down a relational source, maybe sort of a place of joy for the child is really important.
Thank you. This one, I'm just going to read it because it involves numbers. So when looking at the standard deviations in test results, we consider 25 to 75% in the quote normal range. What would we consider when interpreting a scattering of scores, particularly when the majority of the scatter is in the 50 to 95% range and the minority are in the 10 to 30% range?
Okay, so Renee and we're gonna.
I would say so. I appreciate whoever asked that question being so detailed in their numbers. That was helpful. I think, Steph, you probably agree with me in terms of, of course we have, the average range and what that means for a child based on their comparison to others in the normative sample, right? And then we have what these numbers mean in terms of scatter for this kid as a learner, right? So what does it mean that this kid has, a 5th percentile in affect identification or recognizing emotions versus their verbal skills being at the 90th percentile, right? You know, that can be really impactful. We have a child who has a lot of knowledge verbally and has a lot to share, but isn't necessarily using their words to recognize emotions. So I think that when I hear that question, I think about, again, it's outside the numbers, there is that discrepancy, right? And how do you look at clinically what that means as a learner for a child?
I think also it's a matter of, this is some of the skill involved in what we do, which is sort of figuring how things go together and how they don't go together. So if like all of the high range scores are in the critical thinking skills, but all the low ones are in information and, you know, working memory and processing speed, that makes some sense. But if we have a scanner that doesn't make sense, it's like, well, okay, what does that mean? We always, when we have those kinds of things, as a neuropsychologist, you know, when I talk with my students and stuff like that, you got to explain it. You know, you got to know, why is it that this kid is actually really good with comprehension, can answer all kind of questions about social conventions, but still can't read a child's expression on a test, you know, of looking at a kid's face. You know, that's what our job is, to explain why that is, why we think that we have those kinds of discrepancies and what we can do about it.
So it's kind of a warning thing when you see a scattering of scores, you need to look into this a little bit more.
Yeah, it tells you, you got to explain it. You got to know what, wait a minute, that doesn't make it, you know.
Great. Here's one. Talking about reasons to ask for certain things, like in an IEP or in your programming, to reduce potential triggers. Is that a sufficient enough reason to request a small classroom? And what supports and benchmarks can you ask for so a student can learn to be in those larger, more complex settings that might be the trigger settings? So reasons to get a student into a small classroom, or things to help them be in that larger context, which might have triggers.
Yeah. I was going to say, so I think, you know, of course we know, as we talked about, it's hard to make a global judgment of kind of what are the signs and symptoms that would indicate a small classroom versus a large classroom. What are the pros and cons? Really depends on the kid. And when I think about kind of clinically, what this looks like across a lot of kids I've seen is, you know, is a child really not receptive to learning? Are they really not feeling safe? And if that's really the priority and the goal for what we have to do, to me, that's a big sign we got to look at a small setting, right? We got to look at kind of decreasing the demands around this child as a first step. And then once that kind of risk in learning emerges and returns, then we look at, okay, how can we kind of grow these skills in bigger settings and bigger demands, right? So I think, you know, for me as a clinician, I think about the safety and taking risks in learning as a really critical piece to figuring that out.
Yeah, and that's the goal. The goal of them being in the small setting is that we can help them identify and learn how to manage it, whatever that trigger is. You know, it's not the trigger so much, it's like, it's the skills needed to deal with that trigger. So, you know, so then you move up, okay, you know, so the kid can be in a classroom with 6 kids. Can he be in a classroom with 6 kids if there are only 1 teacher rather than 2 teachers? Can he be on the playground without supervision? What happens, you know, is this a child who can, you know, and the other pieces of this too is, well, there are steps to learning how for coping mechanisms. The very first step is, for instance, does a child ask for help? Or does he just go underneath the desk, you know? If a kid asking for help, that's a huge, for many of these kids, they don't trust people. They got good reason not to trust people. They ask for help, that's a big, big step for them, okay? The next step after that is that can they start, you know, trying to manage a couple of things, you know, before they have to ask for help. But, you know, those are all the kinds of steps that we're looking for. I think if you're talking about some of those benchmarks too, what are the line of progress going to look like?
Mm-hmm.
Okay, how can an outside individual, not someone who's an immediate family member or care provider, support a child with suspected developmental trauma disorder if the child is still experiencing this trauma, especially if the parents are not accepting of the diagnosis?
That's a hard one.
Yeah. Are you talking, I think part of the issue is, are you talking about if there's kind of a difference between if there's if you know, someone who's in a caretaking position suspects that there's something bad happening to a kid in the family, that really calls for you know, they're a mandated, you know, responder. They have to file a 51A, you know.
You try to keep the child safe at all.
Right, and so so I think the way that we do this, you know, oftentimes I say to kids when I have to like bring their parents in therapy, is like, you know, I'd rather you be mad at me and never talk to me again for the rest of your life and you're safe than me have to sit and wait, you know, than me have to worry that something really bad is going to happen to you and I didn't do anything to stop it.
Mm-hmm.
You know, and that's a way of putting it. I think, you know, otherwise, I think sometimes it's just really important for us to just, when the kids act weird, to stop and say, oh, okay, wait a minute, what might be going on here? You know, maybe a kid's showing up at your doorstep at like 7:30 in the morning at like, you know, and you don't really get up till 9, you know, just little things like that. Just sort of, you know, maybe a kid just needs a little extra something or other. And maybe you can't do much more than that, but you know, if you can give that little extra something or other, that can make a really big difference for a kid.
Yeah, I would say too, I think Steph said that, you know, the relationship and that connection, you know, as we talked about, is so important. And so if you are, you know, part of that, if you are part of a child's bigger system, you know, as we looked at with that diagram, I think, you know, figuring out what that relationship looks like with that child and how that could be beneficial as a neighbor or someone you see, you know, at school is really an aspect. You know, it's not all of it, but it's a piece of how we support kids who might have developmental trauma or have developmental trauma.
Okay.
I always think of when I was worked in the community of, you know, at the high school, there was, you know, always a bunch of kids who were always getting bullied and kicked around, and everyone thought they were weird and crazy. And there was one custodian in one of the houses, and he just always had an eye out, and they would leave their stuff with him, and he would watch over their stuff, and no one would kick it around. And if they just, I mean, he didn't talk to them, he just was there for them, and they always felt accepted by him. And he was always like a really special guy, the G House, you know, custodian. So that makes a huge difference to a kid to have someone like that in their life.
Yeah.
I have a quick last question because we have just a couple minutes. Can you recommend asking for a trauma-sensitive consult, training, and support in either Grid A or in additional information? Where does it go within the IEP, if that's something you want to ask for?
I would actually, Jenny, you're here, I would suggest wouldn't you put it under additional information?
You could always put it, I think, there, but does it have any more power on a Grid A?
Well, I mean, a Grid A would be the place to put it if you could get it in. I mean, I think that's the consultation to the team is the most important thing.
Okay. Well, you know, this has been fabulous information. I think so much practical information. Thank you so much. For those of you who are still on, I put the evaluation link in the chat box. Please complete that. That would be great. I believe at 1:45, we have about a 15-minute break before the next programming. Stephanie and Renee, thank you so much. It's been really great to learn with you today, you know, just getting our heads around all of this and how we can help our students. So thank you so much for joining us today, and everyone who is on. Have a great day. Continue on, participate in the chats. And I believe your presentation information materials are going to be on the website. So thank you so much for sharing.
Thank you
for having us.
It was great. Thank you all.